So I'm excited to be here with Anna and talk about one of our more complex pharmacogenetic consults. I do not have any disclosures. And Anna's gonna lead the case discussion, but to begin, I'd like to present briefly on some of the interesting aspects of working with commercial pharmacogenetic panels in psychiatry. A little bit of context for our clinic. We have a 0.4 FTE dedicated to clinical pharmacy effort in ambulatory psychiatry. We support a lot of teams, so we've got things like depression, anxiety, bipolar groups in the child and the adult space. So when we work with patients, it's usually through phone encounters to discuss medication concerns. So we might be speaking with folks in the perinatal team about safety of medications in pregnancy or lactation, or checking in between prescriber visits on medication tolerability and response. In the pharmacogenetic space, so this is kind of just mixed into our general role, we also call patients to complete pre-test education calls. We discuss options for testing, expectations, logistics, and we also support ordering, result entry. We have genomic indicators, or we recently started using genomic indicators as of fall 2022, and we complete report interpretation notes and pharmacogenetic post-test calls when requested. So since I started in 2018, we've been working only with commercial pharmacogenetic testing labs at Michigan Medicine. We've explored in-house testing a couple times, but it hasn't really gone anywhere. And really early on, we started to see these kind of interesting issues with some of these commercial products, and how to apply them towards patient care in our space. We also started to see discrepancies between reports. Like we'd have the odd patient or two who would come in with reports from two different labs, and they'd have different genotype calls, different phenotype recommendations, so on and so forth. And when comparing the different commercial products and what we offered to our patients, we saw that pretty much every lab we explored had a combination of high evidence level to implement variants or gene drug pairs, and then usually a solid assortment of pharmacodynamic variants that don't really have extremely robust data to support their use in clinical care. So that's kind of one of the other things we consider when we're looking at labs to use and when we're interpreting reports for our patients. And I think one of the coolest studies, or I think it's awesome, was completed in 2018 by Chad Bozeman and his team. And they did a great job just kind of illustrating some of the discrepancies that we might see commercial report to commercial report when you're looking at products geared towards patients who are using pharmacogenetics to guide mental health medications. So they got 5 patients, and for each of those 5 patients, they set a sample to 4 different commercial pharmacogenetic labs. And then when they got the results back, they basically compared genotype calls, phenotype calls, and medication recommendations across the products whenever there was at least 2 companies testing for the same gene or interpreting the same medication recommendation. And you can see in the first kind of sub-bullet point that the genotype agreement really ranged pretty tremendously. It was as low as 37% for 2D6, all the way to 100% for 2C19 and 2C9. And that's not really surprising for 2D6 if you think about the tremendous number of star alleles. And if you have one lab that tests for a small number of variants, they're more likely to call for a wild type or star 1 if they're possibly missing detecting something another company is looking for. And then this kind of snowballs into phenotype call differences and medication recommendation differences. But the other interesting thing that Dr. Bozeman and his team pointed out was that there were even disagreements in phenotype assignment when the same genetic variants were called, and tremendous differences in medication recommendation agreement. If you look at the paper, they break it down by medication classes. So they'll talk about agreements and medication recommendations by antidepressant, anxiolytic, so on and so forth. But when they looked at it as a whole, there was medication recommendation agreement for only 59% of medications, which is pretty, I thought it was pretty shocking at the time. And really interesting. And when you look at the subclasses of medications, it ranged from about 50% agreement with antipsychotic medication recommendations to 84% agreement with mood stabilizers. So kind of the bottom line that when we talk about this with our trainees, so our, pharmacy students and residents, is always review the genetic results, understand what your product tests, and don't rely only on the decision support tools or maybe the fancy color coding you might be seeing to make those medication recommendations. In our population, we were also making some similar observations when it came to genotype to phenotype interpretations by our most commonly used commercial lab at the time. So we worked with a pharmacy student who did a fantastic job completing a retrospective chart review where we identified patients who had had testing with this commercial lab, and we pulled out 2C19 genotypes identified by the lab. The commercial lab identified phenotype, and then the CPIC assigned phenotype. And we found a substantial range of variability in phenotype assignments that were conflicting. So almost 29% of 2D6 phenotype translations were conflicting for 2D6 and about 30% for 2C19. In this next table, we've highlighted where the most common sources of variability were. And as you scan down the rows, the first kind of block of data is for 2D6, and the second block is for 2C19. You can see that the CL phenotype or commercial lab phenotype and the CPIC phenotype differ, but not all of these differences are likely to be clinically relevant. So in some cases, these might matter. In other cases, they might not. But one kind of glaring one is the very first, where the commercial lab calls the STAR2A, STAR2A ultra rapid, and CPIC considers that normal. So what this looks like in the report decision support tool is basically every single 2Z6 substrate medication looks like it is bad for the patient. They color code it red. They say there's a major gene drug interaction, and it changes the way patients and providers might see these medications, even if we disagree with it. So when we're reviewing these reports, one of the things we point out is discrepancies when they exist between the commercial lab and CPIC, what we would interpret the results as, why, and how that would translate to a medication recommendation. So we already know that there's discrepancies report to report if you're looking at different commercial labs. But the other thing that these commercial products don't do, and I'm not trying to blame them for it or anything, they don't know the patient's full medication list. So they aren't able to factor in drug-drug interactions or phenoconversion considerations. And they don't necessarily know the patient's past medication trial history, as well as any non-psychotropic medications that might be impacted by the pharmacogenetic results. So that's where we try to come in with our pharmacy team. We take these reports, we complete a documentation other encounter where we list, what are the drug interactions? What are any organ function considerations? What's phenoconversion? And what will be recommended next based on the whole patient, considering pharmacogenetics as just another tool to help support medication selection. We've done a decent number of these as of mid-February. It's been about 440, a little bit higher now. We probably complete 3 to 4 a week. And we're starting to do analyses of what are the outcomes of these notes. Like, we feel they're helpful. We think they're pointing out things that might be missed on the commercial lab report. But what do we see when we go back and look at our recommendations? Were they accepted by our providers? And most importantly, what can we do better to make our pharmacogenetic support services more helpful for our patients and providers? So with a current student, we're almost finished with a project where basically she went back, she looked at a time period listed on the slide, and she collected a lot of information about the patients, what pharmacy recommended, and ultimately what were the outcomes. So some of the data collected are highlighted on the slide, but they include things like medication trials and were our pharmacy recommendations accepted. Ultimately, she had time to review about 113 of these notes, and the demographics looked pretty similar to some of those large studies where they've looked at pharmacogenetic guided versus treatment as usual outcomes in patients in mental health. So largely Caucasian, around 40s, mostly female. We saw a significantly higher number of medication trials than we've seen in some of the published clinical studies. And we also noticed that there's quite a high number of drug-drug interactions. And this isn't surprising in the mental health space. There's known to be a lot of polypharmacy and high potential for drug-drug interactions in this group of patients. But when we did an analysis of drug-drug interactions, we were able to identify that about 40% of patients had at least one major drug-drug interaction. And this isn't running it through LexiComp and saying, oh, here's everything. It's looking at like, oh, did they have at least 3 medications contributing to potential risk for CNS sedation? Do they have any D or X level interactions? So that type of thing. We also saw phenoconversion pointed out in about 10-ish, a little over 10% of the notes. And when we made recommendations for next step medication changes, rounding up, almost half of them specifically called out some of the important non-pharmacogenetic factors that were playing into our recommendations. So things like, oh, hey, this patient also has IBS and they're in pain. Maybe there's diarrhea predominant IBS, consider a tricyclic antidepressant. So things like that. And then one of the most, I think, exciting outcomes from our students' analysis of these notes was that 85% of our prescribers directly referenced our recommendations in their next patient encounter. So they were either saying things like per pharmacy recommendations, or they were literally copying and pasting our list of suggested medication next steps into their follow-up encounter notes. And I think that's pretty interesting because we know that when you're relying on things like pop-up alerts, there's a lot of dismissal without really kind of reading them because everyone's overwhelmed by all these pop-up alerts firing. So this is exciting, but there's still a lot we don't know. So we're pairing this with a provider survey where we're basically asking them, like, did you read this? Did you find it helpful? What would you like to see in the future? So we're going to gather that together with our analysis of our students' data shown here, and then we will ultimately publish that. But at this point, I'd like to stop and see what questions there may be before passing it on to Anna.